Okay, so I think we're going to get started. Well, first of all, welcome everyone. My name is Ida Fernandez, and I'm the Executive Director for the Imagine Spore Network. So thank you for joining us today. Our session is one of a monthly training webinar series hosted by the Imagine Network, and it's really aimed at building capacity and improving the design of future research studies. We're really excited about today's talk on sex and gender-based analysis in GI research, and it's being led by one of our research collaborators in the network, Dr. Laura Turgonic, and one of Canada's leading experts on sex and gender issues, Dr. Shannon Ruzycki. First, a few housekeeping items before we get started. So first of all, just please ensure you have yourself on mute throughout the presentation so we can minimize the background noise. We're hoping to allocate about 15 minutes towards the end of the webinar for a question and answer period. So we encourage you throughout the presentation, you can type in your questions using the chat box at the bottom of your screen. Again, at any point in the presentation, just type them into there. And then at the Q&A period, I'll read those questions out to our presenters for them to answer. Following the meeting, you'll receive a link to complete an evaluation survey. So please give us your feedback so that we can continue to improve these sessions as we move forward. The survey responses also allow us to track participation for those seeking the CanMed credits. So please don't forget to complete the survey. Finally, we do record these sessions and archive them up on our website for future viewing. So feel free to visit imaginespore.com if you'd like to share it with your colleagues who weren't able to join us today, and check out our previous training sessions as well. So next slide. So just a little bit about the Imagine Network. The Imagine Network is investigating the interactions between inflammation, microbiome, diet, mental health in patients with inflammatory bowel disease and irritable bowel syndrome. Our mission is to transform the management of IBD and IBS and their associated mental health issues. I also, next slide, obviously want to introduce our speakers for you today. Dr. Laura Turgonic is with the University of Toronto Mount Sinai's Hospital Division of, she's the Division Director for Gastroenterology and Hepatology there. As I mentioned before, she's also the lead for the Imagine Network's Sex and Gender Working Group, and she's the chair of the Canadian Association of Gastroenterology's Diversity and Equity Group. Dr. Shannon Ruzycki is with the University of Calgary. She's a general internist and a clinical assistant professor there. She's the co-chair of the Department of Medicine's Anti-Racism and the Equity and Diversity Working Groups. So I'm just going to pass it over to Shannon and Laura for today's talk.
Thank you for having me. I have no relevant financial disclosures. I aim to use person first and inclusive language throughout my presentation, but I can always do better. Please email me if you see or hear something you think can be improved. We're going to use Menti today. The number is down on the bottom, so you can go to the Menti website and use this number to participate. I want to take a second to acknowledge the traditional and present-day territories of the Treaty 7 region in southern Alberta, where I live and work. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. I think most of you are in Toronto, but if you're not in Toronto, there's a QR code on the bottom of this page that you can use by hovering your smartphone. The QR code will take you to a land acknowledgement appropriate for your region, and it will also explain the importance of land acknowledgements in Canada's Truth and Reconciliation. The city of Toronto is on the traditional and present-day territories of many nations and is now home to many diverse First Nations, Inuit, and Métis people. These are the CanMed's roles we're going to address today. These are our learning objectives for my portion of the talk. We're going to discuss sex and gender, equity, diversity, inclusion in research. So what is sex and gender? So sex is biologic, but it's not necessarily straightforward. The CIHR defines sex as chromosomal sex, which in turn influences our other molecular, immunologic, and physical expressions of sex. But how often in our studies are we actually looking at chromosomal or genetic sex? Though it is biologic, it is not necessarily black and white. There are disorders of sexual diversity or sexual difference where there may be a mismatch among one or more of these biologic factors. And an example is 5-alpha reductase deficiency. And this is a spectrum of disorders that can lead to intersex conditions. Conditions where there may be a discordance or mismatch between the biologic attributes of sex. So in this example, someone with chromosomes in keeping with male can develop a gene mutation and then lead to the development of internal male structures such as testes, but ambiguous external genitalia. Historically, some of these people with ambiguous genitalia may be surgically altered at birth, or the person could be inappropriately deemed female at birth, live their lives as a female or a woman, and then when they have a surge of male hormones during puberty, develop secondary sexual characteristics in keeping with male, leading to masculization. And this is an example of one of the many disorders of sexual diversity that can lead to this discordance in biologic sex. So there's a spectrum of biologic sex beyond male and female. So our first Menti question is going to be, what is listed on our patient's medical records? Is it sex? Is it gender? Is it chromosomal sex, hormonal sex, external genitalia? And I'll give you guys a second to look at this. This is important because when we're doing large registry studies or when we're addressing patients, we can see male or female on the medical record, but what are we actually looking at? So I'll open up our Menti responses. Oh, did I stop? Sorry, I didn't start presenting it. Okay, give you guys a second to answer. Okay, one person has responded so far. Great participation for that one person. Thank you. I'll give you guys a second. So the code is on the top of the slide here. So if you go to menti.com and enter the code 98261701, you get to use your phone during the presentation. And I will just refresh the page to see the rest of your answers, which hopefully you've put in. We'll see how much you guys know about sex and gender here. Oh, just the one person. Usually people like to be on their phone. Oh, thank you for the 2 people who put gender. Thank you. Great participation. I'll give you guys another second to think about this. It influences our studies as well. So when you're looking at the results of a study or you're reading a study that used large registry data, you're using whatever is listed on the patient's medical record. So it's important for us to understand what exactly are we reporting and measuring. Okay, let's see here. So most people have said gender and some people have said chromosomal or genetic sex. So thank you guys for participating. I appreciate it because I made my slide here. Now hold on, I'm still screen sharing. I'll go back to my presentation here. So the correct answer is actually something called legal gender. And that's based on your sex assigned at birth. So when a doctor examines babies after they're born, based on the external genitalia, a doctor will assign female or male, and that goes onto your permanent medical record, your legal documents, and that's called a legal gender, and we use it as a surrogate for sex. But you'll note that nobody examines your chromosomes and then puts that on the file. So even though CIHR defines sex as chromosomal sex, what we're using on our medical records is actually legal gender, which is based on external genitalia. So sex defined as external genitalia. An estimated 1 to 2% of all people in North America are intersex or have a diversity of sex development. And that means that they are not strictly male or female in the way we usually think of those terms. So that's 1 in 100 or 1 in 50 participants in all of your studies that might be, if you're using male or female, might be different. And do note that in Canada, legal gender also includes a third option, which is the X option. So a lot of studies that don't include female, male, and X as an option are inaccurate. So gender is a social construct, but that doesn't mean that it's wishy-washy or not important in science. Gender identity refers to how one perceives themselves. Gender expression is how one performs their gender, and gender role is how responsibilities and occupations are assigned based on gender. And so these things are culturally influenced. CIHR also includes gender relationships and institutionalized gender, which we just won't have time to talk about today. So this is our next Menti question. And I want to ask you guys, what is this person's gender? And I'll give you a second to think about it. And while I do that, I'm just going to make sure that the slides are accurate on here. So I'll go back and then I'll continue with the presentation and we'll come back to the question. Okay, so what is this person's gender? And you can type in whatever you think and we'll just continue. Okay, so gender identity refers to how you perceive yourself. And the only way to know someone's gender identity is to ask. So you cannot assign a gender identity to someone else. It also can change over time and throughout someone's life. Examples of gender identity would be something like woman, demigender, or non-binary. And these terms are updated all the time based on people's understanding of themselves. And people may use a term that you don't understand. You can just look that up on the internet. It's quite straightforward. So gender expression refers to how we perform our gender. So can you really tell what someone's sex is just by looking at them? So we aren't seeing each other's chromosomes. So how are we communicating our sex or gender? In Western culture, you understand that I identify as female or as a woman because of the length of my hair, whether or not I wear makeup, the clothes I wear, whether or not I have facial hair, my shoes, etc. And so this is the way that I communicate to you who I am and certain aspects of my identity. This actually can be formally measured. So though it is controversial because it relies on gender norms and expectations that can fluctuate over time, you can still use different types of questionnaires to see how people perform their gender. And this can be important in terms of activating misogyny, sexism, or implicit biases. Examples of gender expression include feminine, masculine, and androgynous. Gender roles refer to the occupations and responsibilities that are assigned to someone based on their gender. You can measure these using a questionnaire developed by Christine Norris at the University of Alberta, and it includes things like who is the primary caregiver in your house, who is the primary income earner, who does the majority of housework. And these things are very important in a lot of studies, which I will show you later, how that can interact with healthcare. Okay, so let's go and see what you guys answered. I hope you guys typed some things in. I really appreciate it. Okay, cool. Okay, so this person's gender, is it female, androgynous, male, unknown, pangender? So the answers that are the biggest on here are the ones that were answered most frequently. Non-binary. Okay, I really like what you guys are up to here. I'll review for you what I think is the correct answer. Oh, sorry, that's just my email, of course. Where did I put my PowerPoint presentation? I'm a millennial, but I don't know how to use the computer. So it's like an ongoing problem for me. Sorry about that. Okay. So this is Harry Styles, and he is a British singer who was previously in One Direction, but now is a solo artist whom I love. Harry Styles uses he, him pronouns, which is compatible with his gender identity as a man. So note that we use the terms male and female to refer to someone's sex, whatever we're using, whether that's legal gender assigned at birth, chromosomes, hormones, etc. So he uses he, him pronouns, so we can assume that well, we don't know for sure, we can assume that he identifies as a man. We would have to ask him his gender identity to know for sure. Because remember that gender identity is how you view yourself. His gender expression is fluid. So he wears makeup or outfits that are typically considered either masculine, feminine, or androgynous, depending on how he seems to feel that day. So his gender expression really fluctuates. And his gender roles are unknown to me. So I don't know what kind of gender roles he uses in his life. Another example is Sam Smith. So Sam Smith is also a British singer. And Sam Smith uses they, them pronouns, and they have announced that they are gender non-binary and gender fluid. Their gender expression is also fluid. So at times they wear makeup or outfits that could be considered masculine, feminine, or androgynous, depending on the situation. So you'll notice here that they are wearing a lace blouse with a really cool blazer over it. And again, their gender role is unknown to me. So you can see how these different aspects of gender can be similar or overlapping. So with the gender identity, you just have to ask somebody and you can base it on their pronouns or what they describe to you. But it's not related to gender expression. It's not related to sexual orientation, and it's not related to biologic sex. So gender has different components, sex has different components. They can overlap to influence our health and our health research, but they are distinct, okay? So how does this translate to our practice? So in clinical care, we need to honor patients' gender identity by asking them how they prefer to be addressed and which pronouns to use. Using correct pronouns can prevent dysphoria and can build rapport and trust. We need to understand how gender expression can activate our implicit and explicit biases. So, for example, we know that when gender expression violates our gender norms, patients can have worse clinical care. So, for example, we can call men who appear feminine, express their emotions as whiny. Women who are argumentative or assertive or otherwise masculine, we have terms like bossy or aggressive or other terms. And so that can activate our biases. Gender roles have been shown to influence recovery time after procedures. So those who are in caregiving roles have a longer recovery and more pain after discharge from hospital compared to those who do not have caregiving roles. And that's regardless of their gender or their sex. So we can use being a woman or being female as a surrogate because we know that women and females have more caregiving roles based on our gender norms and our culture. But that doesn't get to the key of what we're actually looking at. So being a woman or being female is a surrogate for caregiving roles, which is related to prolonged recovery time after a procedure. In research, we often use legal gender based on external genitalia seen at birth as a surrogate for biologic sex. But there are many cases where this isn't enough detail. So, for example, in cardiovascular or thromboembolic diseases, hormone status may be more important than a patient's external genitalia. So, for example, would you consider postmenopausal women to be more similar to premenopausal women or more similar to men from a hormone perspective? And how might rheumatologic or infectious diseases, which may depend on immune cell differences, differ between transgender women and cisgender men? If 1 to 2% of a study population are intersex, how does this influence your study results if you're categorizing people's hormones or immune cells differently or incorrectly? When we use gender in studies, what do we truly mean? Are we interested in experiences of sexism, which may be more similar for males who have a feminine gender expression and women? Are we interested in how caregiving responsibilities influence our ability to seek care, which is more of a gender expression or a gender role rather than something that all women share? So we need to use our terms correctly during data collection and study design to sort out these differences. So male and female are not genders. They are used to refer to sex or legal gender, however you're using these terms in your study. And in Canada, X is a legal gender and should be, is one of the legal genders, which should be included in your sex question. For the second part, women and men are not sexes. They are gender identities, and listing only women and man is exclusionary and implies a binary gender dynamic, which is not true for either sex or gender. Do not list other as a gender or as a sex. It implies that being a man or a woman is normal or the correct option, and anything else is just a catch-all category. So what is the right way to do this? When you're asking sex and gender, you should separate them on your questionnaires to understand how sex and gender may be related to your outcome. So when you ask, what is your sex assigned at birth? You need to include intersex or an X category. You can ask, what gender do you identify with today? You can list man, woman, a non-binary gender with a text box, or a gender not listed instead of gender as other. You can also use open text responses, which is the most accurate way to ask about gender, but then you have lots of non-overlapping categories that can make that harder to analyze. But if you use a variety of terms, it's a bit reductionist. So it depends on what you want to know based on your study question. How do we incorporate other principles of EDI into our research? So when you're doing research training, everybody gets a background in statistics. Everyone learns a little bit about the different study designs. Everyone learns ethics. But what's missing from our foundational understanding of research is how to incorporate EDI. And I think this is really important. And I can give you an example of why all trainees should have this foundational understanding. So this is a recent study that was published at a Johns Hopkins University, where I did my master's degree in 2020. And it looked at comparing nurse practitioners and gastroenterologists performing colonoscopy screening for colorectal cancer. And when we look at their table 1, something you'll notice right away is that African American or Black patients made up nearly 3/4 of this study population. And in this clinic, Black patients only account for 30%. So their Black patients were vastly overrepresented among the study population. So why does that matter, or why could that have happened? It's also interesting because in most studies performed in the US, Black patients or non-white patients are vastly underrepresented. So we have a bit of anomaly here. We have a study where Black patients were overrepresented when it's usually not the case. And why is this problematic? Well, in this study, we're comparing the quality and the safety of a scope performed by a nurse practitioner to a gastroenterologist. So at the beginning of the study, it's not known if the patients entering into the study are going to get the same quality of care. And though no difference was ultimately found, so nurse practitioner scopes were non-inferior to MD scopes, at the time of the study, it was recommended against, and we didn't know. And this is further problematic because we know that Black patients in the United States have higher rates of colorectal cancer and a greater mortality rate from colorectal cancer. And so therefore, you would argue that they should receive the best care at baseline. So there's a question here of, is this perpetuating racism? Is this an example of structural racism where patients were taken into a study where they may have had worse care in a population that may have already had worse outcomes to begin with? So understanding these foundational principles is critical for anyone doing any type of research. So what are examples of these tips? So you have to understand, what does it mean to be marginalized and what does it mean to have privilege? And I have resources on the bottom on how you can find these things in QR codes. You need to learn and acknowledge the history of your field. So you need to understand who are the key scientists, the key researchers, and the key research studies in your field, and how was EDI incorporated or missed in those studies. So a great example of this is in the surgical fields. A lot of the equipment used in surgery was named after prominent surgeons, but those surgeons gained their reputation and their history by doing studies on enslaved Black people, especially enslaved women in the United States. And how does that history of oppression not acknowledged? And what does it mean when we don't talk about how some of these prominent people who we look up to may have contributed to oppression in the medical field? What does that mean to our colleagues? We need to meaningfully partner with marginalized communities. That means meaningfully building trust, listening, and understanding what are the research or medical issues that are most important to that community. And that means that sometimes when you approach a community with a study that you might want to do, that might not be the study question of most interest to that population. And so sometimes that means not doing the study that you want to do, but doing the study or the work that's most important to that community. We need to build capacity within marginalized communities to do research and compensate those people appropriately. So we know that there's underrepresentation of racialized or Indigenous researchers in Canada, and that leads to disparate research and disparate outcomes. So it's not right for someone with a lot of privilege, like for example, myself, I'm a white woman settler, to do research in Indigenous or racial minority communities and then not provide any training or scientific understanding or building capacity to continue that work in the community. So ways that you can do that are getting research assistants or students or people involved in your research who are from those communities. And you can do that by reaching out to racial minority student associations. So there's a Black Medical Students Association. There are alumni groups or places that you can find people who are not always the first people you think of when you are building a research team. When you bring in those people, sometimes they may not have, because of exclusion and racism and other factors, they may not have the skills that you think you need for your research team. And the onus is on you to train those people and to teach those skills. And that's what building capacity means. And when you're taking someone from a marginalized or underrepresented community and bringing them onto your research team, you must compensate them appropriately. So you have to pay them a research assistant wage, and that's to avoid appropriation. So you need to be building that into your grants and your budgets. You need to disseminate your results to marginalized communities in a way that they can apply and understand. So it's not appropriate for you to do research on a community, publish your results, get your promotion, get your scholarship, get your glory, and then to not meaningfully translate that research into the community. And we'll talk a little bit more about that. You need to consider data ownership. So I have the link here for OCAP, which is predominantly for Indigenous communities in Canada, but who owns the data that you collect from a marginalized community? You need to use respectful language. So the language used by marginalized communities differs. So for example, the deaf community prefers to be called the deaf, but other communities prefer person first or patient-centered language. And so you need to research what language you need to use in your community. And partnering with social scientists is really helpful for understanding things, especially things like gender or race, which are social constructs or cultural ideas rather than biologic concepts. So you need to understand the difference between a biologic classification and a social classification. And social scientists are experts in this. And so building your research team with people with different areas of expertise is really helpful. So we've all heard that it takes 17 years for research to become common practice, but is this adequate when it comes to discrimination or bias in research results? Or is this apply when you're doing research on a marginalized community? Can you wait 17 years to make sure that that research benefits those communities? And I would argue no. Any research that has an EDI component has a unique requirement for us to turn our findings into action more quickly, and especially if you're from a privileged group. So knowledge translation in EDI research is actually just advocacy, and I can give you some tips quickly on how to do this. So an example from my own research is a survey I did with some learners in Alberta that looked at barriers for women returning to work after a parental leave. And we found that time and space for lactation upon returning to work was one of the most important barriers. We were writing our manuscript, we did a literature review, and we found that there were multiple studies that described those same barriers: space and time for lactation at work. So we got a librarian and we did a systematic search, and we found 73 studies that showed that women returning to work after a maternity leave as physicians did not have adequate space and time to breastfeed. And we published a scoping review on this topic where we said, hey, there's a lot of studies, they have similar methodologies, they're in different places, but they've all found that women physicians do not have adequate space and time to breastfeed when they return to work. So, I publish this and, I get my promotion and I move on. Well, it's not enough just to publish these barriers. What are we going to do about them? So during our scoping review, we identified Canadian and American legislation that guaranteed appropriate space and time accommodations for anyone returning to a workplace to accommodate lactation. And so what did I do? I talked about this all the time. I said, hey, do you guys know that it's required for us to support time and space to breastfeed at work? And we're not currently doing this in Alberta. And I mentioned it everywhere. I mentioned it at Grand Rounds. I mentioned it in casual conversation. I did speeches. I called people from Alberta Health Services. I called program directors. I wrote little policy briefs and sent them to everyone whose email I could get a hold of. And after about 6 months of me just buzzing around about this issue of inadequate lactation support at work, Alberta Health Services created a policy that all AHS facilities must have lactation space for healthcare workers. So it's a big win. So how can you take these principles and accommodate them, whatever your EDI research is? If it's about racism in IBD research, is it about inadequate support for women caregivers in inflammatory bowel disease? Start by solving a problem for your leadership. And it might be a problem that your leadership does not know that they have. But for example, I just buzzed around all the time saying, this is a legal risk to our medical school. We do not have lactation space, and we are required to do so. And I just created that problem, and I just kept talking about it every day. And I said, hey, do you know what the solution is? It's this space, etc. And I just talked about it all the time. Sometimes starting with low cost or free initiatives can get momentum going and building that momentum for greater change if possible. When you have local data, it can be more compelling. Often with EDI work, I hear, well, that's a problem in the United States, or we don't have that problem here. But when you have local data, local surveys, et cetera, you can say, actually, this is a huge problem here. We didn't even know about it. And that local data may already exist. It doesn't always mean that you need to do your own huge research study, but your provincial medical association may have it, your university may have access to that data. And so sometimes even taking data you already have and segregating it into legal sex or gender, you can really get somewhere. Knowing the literature is critically important, even if the literature doesn't exist yet. So you can do a scoping review, a quick survey, looking around saying, how do we know this is a problem in our area? And bringing up a lot of facts is always very compelling, especially in scientific fields. Building expertise by educating yourself on these topics and learning a lot about them makes you the go-to person. And then that can get you a seat at the table. So joining any committee, working group, or any place where you are with leadership with people who make decisions. And then when you're there, using that seat at the table. So even if it's unrelated to GI or IBD, once you get a seat at any residency training committee anywhere, speaking up and saying, hey, do you guys know about this problem? This is what the literature says. This is what we know about it in our setting. It can really get the right people listening so that eventually you get in front of the right person to solve the problem. And listening and listening and listening to marginalized groups when they talk about what their issues are. A great place for this is social media. So following activists on Twitter or Instagram to understand how people are being influenced by these issues, and they exist, and you can start to see what the problems are. This is a slide with a bunch of QR codes on how to learn more about these topics. So how to understand your own biases, how to practice anti-racism, how to speak up when you see something clinically that's not appropriate, how to learn about history, and they're all here. So you can take a couple of seconds, screenshot it, and we can send these out afterwards so that you can better understand how to incorporate these principles into your own work. And I will pass over now, I am done my session. And I think, will we save all questions for the end?
Yes, we will. I've been asking people to just enter your questions into the chat box for now, and then we can field them at the end of the presentation.
Okay, perfect. Okay, thank you guys for your attention.
Laura, are you able to project?
I'm just getting set up, and I apologize.
That's okay.
I'm just trying to figure out how to get the right screen on the. Yeah, I've got like 4 screens here, which is great for launching a shuttle, but it gets me all confused when I'm trying to. So, good afternoon, everyone, and thank you for joining us today. First of all, I want to thank Dr. Ruzycki for an excellent presentation, giving such a broad overview of the importance of integrating sex and gender into research. And I do have a question at the end, and I will save it for the end, that addresses a practical concern that I continue to have. And I also want to thank her for taking care of the land acknowledgement. I think understanding what's going on in the world and respecting inhabitants of the land, I think it's just an important thing to remember. This is our issue in Canada. It affects people around the world. So I want to thank her for taking care of that. So just to go through a little bit, my disclosures, I have a few more than Dr. Ruzycki, for better or for worse. I'm thankful for my sponsors and for my ability to participate in this. Yet, of course, it can potentially influence my work, so here they are. And here are my CanMeds roles. And I'm going to, I have sort of a broad array of learning objectives, and I may not get to all of them today. But I do want to focus on a few areas. Of course, the impact of sex and gender on inflammatory bowel disease and on gastrointestinal symptoms in general is quite large. And my goal for today was to see if you can focus it on IBD, even just to try to limit the scope of the conversation. But even within that, the topic's quite broad. And I may not get to all of it today, but I at least hope to sort of illustrate the importance of applying the principles that Dr. Ruzycki elaborated on in the management of inflammatory bowel disease. So in terms of the learning objectives, I want to first of all propose a model for understanding how to incorporate sex and gender into our understanding of inflammatory bowel disease, and in particular, how it may inform our development of research questions into understanding IBD and why it's important to incorporate sex and gender into the conception of those research questions. I want to also talk about a little bit why this is important. Now, there may be some that are important and some that are less obvious, so I want to go through those at all. And then I'm going to use a couple of case studies that I'm hoping to be interactive to try to illustrate some of our illustrate our current knowledge pools and our gaps in inflammatory bowel disease. And then I want to finish off with some of the ways that we can potentially use this collaboration to address what we're already doing through this collaboration to address some pertinent questions as it pertains to the care of patients with gastrointestinal symptoms that may turn into inflammatory bowel disease or irritable bowel syndrome, and also provide a framework for creating future research questions and harnessing the strength of this collaboration to answer those questions. So I want to start with a brief disclaimer. Dr. Ruzycki gave a very thorough presentation about sex and gender, and so we often think of sex as being sort of dichotomous. You have male and female in terms of the biological or the biophysiological influences that we often ascribe to maleness or femaleness, but we understand they exist on a spectrum. The same applies on gender, whether we're talking about gender expression, gender role, gender identity. We often think in binaries of man and woman, yet we hopefully now understand that those may represent just the extreme forms or ways that we group similar but not identical forms of gender role or gender expression. And so the disclaimer that I want to use is that in spite of this, much of the research that I'm going to be presenting is based on the primacy of a gender binary. And it's important to recognize that because much of the research that I'm going to be presenting was not recorded using sort of expansive definitions of sex and gender, that the conclusions that we can draw from them are going to be imperfect. It may, and it forces us to maybe generalize about sex and gender when we recognize, use an example that Dr. Ruzycki mentioned, that there may be differences between a premenopausal and postmenopausal woman, or a cisgendered female and a transgendered female that may not be captured in this framework. So I'm too planning on using Menti, and I want to just start with one question that we'll talk about briefly. So I'm going to leave this open for people to ask a question. I'm just going to sort of present this here. I'm going to switch over my screen. So if you have a chance to go on this, I'm using a different code than Dr. Ruzycki. And I just want to ask a very open-ended question, just to sort of frame this, which might seem like a silly question at first, but I think I'm hoping it elaborates on some of the challenges that we face, which is, why do we even bother? Why should we study sex and gender in inflammatory bowel disease? So I'm hoping people can contribute some of their thoughts. If you don't, I've got some of my own to share. Can everyone see that on their screen? Okay. So I'll wait until there's about 3 or 4 on the screen, just so I can. Or maybe just 2. Okay, here we go. Great. So this covers a lot of ground here. So I'm just going to share back my screen here. So, what I'm seeing here in terms of why study sex and gender in IBD. Oops, sorry. So I see a lot of things, like, and probably the one that stood out to me the most is that it's the right thing to do, which I think is ultimately true, but I think it's important to understand why it's the right thing to do. So in terms of, so I think I want to thank the audience for covering a lot of the ground here. So the first one might be the most obvious, which is that it might provide insights into the etiology and pathophysiology of disease. So understanding that people who are deemed to be male or deemed to be female, having different outcomes, showing a difference in incidence and difference in disease progression, might give us insights that might try to have us explain, well, why is that happening? What is it about sex or gender that's driving that? Of course, Might potentially provide prognostic information. Knowing that men and women might respond differently to therapy provides important information on how we might treat a patient. We want to understand, I think as someone said, the experience that men and women can influence their disease course and experience. So gender might have impacts on the disease experience, things like quality of life, satisfaction, the ability to work in one's occupation. That would be important to understand because the advice we give these people or the accommodations we might make might be very different for people with very different gender expressions or gender identities. Ultimately, we want to minimize the impact of unconscious gender bias. Unconscious gender-based determination. So if a physician or a healthcare provider makes presumptions about patients based on what they perceive their gender to be, and that forced them to institute an alternate pathway of care, that could potentially have significant differences in outcomes. And ultimately, when we say it's the right thing to do, it's because ultimately your sex or your gender shouldn't determine the quality of care you receive. And by that, I mean the type of care you receive and the outcomes associated with that care. So when we talk about a model of why people get inflammatory bowel disease, you've probably all seen things that are similar to this diagram. Yes, you start with your genes, some genetic factors, and then there's, of course, the impact of both our external and internal environment. And those all affect things like our physiological milieu, sort of the stew of hormones and of cytokines and cells and signaling that goes on in our body. Genetic factors and environmental factors also impact the gut microbiome. And the gut microbiome, the composition of the gut microbiome, the degree of diversity is going to be affected both by the genes we have as well as environmental factors like where we live, the foods we eat, the people we hang out with, the types of behaviors we adopt, and also obviously impacts on neuroenteric function. And all these things act together to to regulate the immune system. So whether you have what we call immune regulation or dysregulation, just to speak very broadly. And this in turn will impact on the degree of inflammation that we might have in our guts at any one time that might vary from being uninflamed to having a state of severe inflammation. The type of phenotypic expression that you might have with your inflammatory bowel disease, and the development of things like extraintestinal manifestations. So where does sex and gender actually fit into this? So putting up this framework again, I'm going to plug sex and gender in here because, of course, your genes, I think we don't have to elaborate too much on this, to some ways determine your biologic sex, but also environmental factors like medications you do, the kind of foods you eat, might also influence your sex and your gender. Now, how do these actually impact on the kind of things that might affect immune dysregulation and dysregulation? So of course, these things can work together. So your sex can influence your physiological milieu, your gut microbiome, and your neuroenteric function. But also your gender can too, and it mostly does that by impacting on your behavior. So things like your gender role and your gender expression are circumstances by which you might walk through the world in one way that might affect the kind of choices you make. And those potentially could also affect your physiological milieu, your gut microbiome, and your neuroenteric function. In addition, it affects your circumstance, which is the way that people perceive your gender, and can also change your circumstances. It may cause physicians or healthcare providers to treat you in different ways. It might affect your access to healthcare services. It might affect the kind of foods you eat and the habits you pick up. And those things in turn can affect your physiological milieu, your gut microbiome, and your neuroenteric function, which all can have impacts on immune regulation or dysregulation. So when we're asking questions about sex and gender, it's important to always consider those when we're talking about the various phases of inflammatory bowel disease. So if I'm looking at the incidence of inflammatory bowel disease, and I'm going to go into this example in a little more detail, such as who gets inflammatory bowel disease, when do they get inflammatory bowel disease, how do they get inflammatory bowel disease, what type of pattern of inflammation. It also affects the course of IBDs, all these different things listed here. And in addition, any question that we have about the experience of living with inflammatory bowel disease, such as your symptom burden, how you utilize healthcare services, the behavior of your practitioner, the degree to which you feel the ability or disability, and the degree of empowerment or disempowerment within the healthcare system, and of course the impacts that it has on sexual and reproductive health. So I know our time is short, but I do want to get to one specific example, and I want to sort of, once again, reach out to the audience to discuss how this might impact on sex and gender. So So here we have an important study that was done by Salisha Shah and Hamid Khalili back in 2018. And this represents a systematic review of all cohort studies that aim to look at the difference in rates of the incidence of inflammatory bowel disease, being Crohn's disease and ulcerative colitis, by age, but stratified specifically by gender. And what we see is anytime the curve rises above the line, that there is a female predominance in the incidence of gender. And anytime it falls below the line, we're referring to a male predominance. And what we see is that over time, we see the following changes. So one of the things I wanted to highlight is that we see that in Crohn's disease, that we start to see a female predominance in incidence starting at age 15 and extending right through adulthood and your senior years. For ulcerative colitis, while there is a female predominance early on, we start to see a male predominance later in disease. So I want to sort of flip this back and say, well, how do we address a question like this? Because clearly we have a measured difference, and there seems to be an impact on age, an interaction between age and gender on the incidence of inflammatory bowel disease. So I want to ask a couple questions once again of the audience. Oops, give me 1 second here. Sorry, as I struggle with sharing screens again. So once again, I'd like you to go back to the menti.com page. We see what sex-related factors might explain the differences in the incidence of inflammatory bowel disease. So a lot of people are talking about hormones. So what might affect my hormone levels? Because there's that sort of an obvious difference. We see things like we see that there's a rise in the incidence around the time of female puberty. And so we're seeing hormones, which is a reasonable thing to think about. Perhaps there are sex-related differences in immune dysfunction. That's also good. So then the next question I have is, what about gender? So someone had mentioned things like, there could be differences in the kind of foods that people eat or the kind of exposures that people have, the work environment, excellence. So whenever we're addressing a question like this, it's sometimes easy to say, well, it starts at puberty and males tend to predominate after menopause, but these could also be informed by gender. Sexism of healthcare workers. So there may be differences in terms of how readily we're ready to diagnose a disease. Bias against women with abdominal pain. Excellent thoughts. And I wanted to talk briefly about these in a little more detail. So I'm going to go back to my presentation. So we talked a little bit about any differences related to the impact of sex, any differences related to the impact of gender, and then also understanding if these differences are real. So I want to talk about another sort of illustrated point, which talks about the role of gender, and then I'm going to wrap up. So So when we talk about things like diagnostic delays, so one of the concerns that we often have is that there's often a time between someone going from having IBD, but no one really knowing about it, to the time that they're actually diagnosed with inflammatory bowel disease. And there's a pathway that has to happen for that to happen, for someone to not have inflammatory bowel disease where they don't even know about it, to actually getting confirmed in a confirmed diagnosis. So the first thing is the patient has to have a reason to seek healthcare. You're not going to get diagnosed unless you actually make the effort to get in contact with a healthcare provider. The patient actually has to seek healthcare. So once you have a reason, you have to sort of think of, well, what are the potential barriers that might keep someone from actually getting to a doctor? That healthcare provider has to take in that information and be suspicious of inflammatory bowel disease. That healthcare provider has to order a diagnostic test for IBD, and those tests need to be determined and ordered and prioritized. And then those tests need to be interpreted. And at any step along the way, the impact of sex and gender could potentially influence the types of decisions that may be made at different stages. So when we look at this, so this is a study that was done about 10 years ago, where they did find a trend towards an association that women were less likely, more likely to have diagnostic delay, especially for ulcerative colitis. Although we have to keep in mind here that this is a systematic review of 9 other studies that were not specifically looking at the impact of sex or gender on diagnostic delay. But I want to show some research that we did a few years ago. Which showed it. So what I'm presenting here is a study we did to look at opioid use in IBD. And opioid use is important because opioid use is often a marker of undiagnosed IBD. People come in with abdominal pain, and if there's not a strong suspicion for IBD, or for whatever reason that diagnosis isn't made, we often will use opioids non-specifically to treat chronic pain. And what we see is that when we looked at male cases versus controls, which are the blue lines, the thin and thick blue lines at the bottom, we see that there's not much difference in the opioid use in men and controls who didn't have IBD prior to the diagnosis of IBD. But when we look at females, we see there's a significantly higher rate of opioid use among females with inflammatory bowel disease prior to their diagnosis compared to controls who didn't have inflammatory bowel disease. And it's also higher than it is among men. This sort of builds a story that perhaps when women are coming with symptoms of IBD, that their diagnosis potentially is being delayed. And the opioid use may be a marker of symptoms that are ongoing that perhaps are related to undiagnosed inflammatory bowel disease that is being treated empirically and poorly, probably with opioids. So I want to sort of stop here. I know we have 4 minutes left, and I know there's questions in the chat. I'm sorry I'm not going to get to the whole thing, but I will post my entire slide set online. I don't feel badly about this because I think the first half of the presentation was excellent and very much worth hearing. So, but I will put these slides online for anyone else, but I do want to open it up to any questions that people have.
Thank you so much, Laura. Clearly there's a lot to unpack here, and if you're open and willing, we'd love to invite you back to go through the remainder of your presentation, because there's obviously some strong interest here. But thank you for allowing us a few minutes to answer some questions at the end here. And again, I encourage others, you feel free to type in the questions if we don't have time to answer them today. I'm sure Laura and Shannon would be happy to answer them over email. So we would go ahead with that as well. So maybe just a first question here, I'd say for Shannon. Are there any studies that examine the rate of intersex or non-binary participation in research studies? And does that match sort of the 1 to 2% prevalence in North Americans that identify as non-binary? And if you could expand on that, what do you feel might be some of the barriers that exist for these people to participate in research?
Well, I think there's 2 aspects of that question there. So transgender is a gender, and intersex is a type of sex diversity. And so I think that the rate of non-binary gender individuals is unknown in the general population, and maybe as much as 3 to 10%. And the intersex or disorders of sexual diversity is about 1 to 2%. And so a lot of the times these are not reported in studies. And so there's a large scoping review looking at participation in certain types of trials, most specifically neurologic studies. And most studies do not report that participation rate. And I think the reason for that is because we do not ask correctly. So if you're somebody who identifies it or is intersex, there's, male, female, and there's no other option for you to select, then who knows what you choose. So you may stop participating in the survey because it doesn't seem to apply to you, or you may just choose male or female to move on. And oftentimes we don't ask about gender diversity. We ask sex as male or female, and then we don't leave any other room, or we combine things incorrectly. So I think one of the biggest barriers to having that information is that we as researchers are not asking those questions correctly. We're not reporting those results when we have them, and therefore we're doing a really poor job of having that data. So we can't really even say how people are experiencing the world, or how they're experiencing medical care, or how outcomes may differ for them, because we are not collecting that data appropriately.
Thank you. Yeah. And Laura, maybe just this question for you. Is there any indication that male prevalence of UC is due to increased number of prostate exams, for example, in older men?
So it's a good question. I don't have a definite answer. My suspicion is no, just because it's relatively rare to sort of just find blood on a digital rectal exam in someone who isn't presenting with those kind of symptoms. But it does raise the question of what we call case ascertainment bias, which is how much of differences in incidence might be driven by differences in both in healthcare seeking behaviors and how symptoms are interpreted by physicians when healthcare is being sought. So as an example, women are much more likely to seek healthcare for both physical and mental health conditions. And also, especially during reproductive years, there may be a lot of just well-woman care that women seek more than men. On the other hand, what often that leads to is that there may be a perception that when men actually come to the doctor, that it must be a serious problem. And the question is whether that is more likely to then get investigated, and the type of diagnostic testing or the seriousness that is bringing to this. So I did send a survey along, and I didn't get a lot of results, but the question that I was trying to pose we sent a lot of a quick case vignette to all of you earlier. And this is actually a research question that Dr. Ruzycki and I are hoping to address, which is, when you receive a referral as a gastroenterologist and you're told that a patient is male or a patient is female, but all the other information is the same, is how does that affect your triage decisions? How does that affect the urgency at which you might appropriate some symptoms? And how does it affect your perception of the likelihood of what you believe the diagnosis is? Because that's going to affect your choice of diagnostic testing. And our hypothesis is that when women come to see their doctors with GI symptoms that may represent inflammatory bowel disease, that all things being equal, the types of investigations that they receive may be different and probably qualitatively less likely to attain a diagnosis. And so this is a hypothesis that we want to test. And we also think that having a comorbid mental health condition may widen those differences, so that women, particularly women who report depression or anxiety or other psychological distress, how seriously those symptoms are taken and to what extent those lead to certain types of diagnostic investigations may be very different.
Thank you. So I see we're past our 1 o'clock timeline, and obviously want to respect everybody's commitment here. But I just want to take this minute to thank you again, Dr. Ruzycki and Dr. Turgonic, for this very informative presentation. We obviously need to continue to explore more on this topic, and would love if in the future you might have some extra time to continue to present results in this area. So thank you to our speakers. Thank you to our participants for joining us today. Yes, sorry.
One shout out. First of all, thank you all for coming. And the second is, is we do want to build research capacity to study sex and gender within the Imagine cohort. And there are a lot of great questions. The core of my talk was that there's a lot of great questions, and most of them haven't yet been given the time of day. We have an opportunity to potentially address these questions. And if there are students or researchers who are interested in this, please email me. I will type my email into the chat, and I'm otherwise easy to track down as well, because I think there's a lot of questions that can be answered, and I think we have a lot of the tools through the Imagine cohort that may help us answer these questions.
Great, thank you. And we'll certainly share that information when we send the survey out. So there is a mechanism for people to get back to you. And as I mentioned, Dr. Turgonic is the lead of our sex and gender working group, which is exploring some current studies right now in sex and gender based, but there's obviously opportunity to continue to answer, to pose more questions and answer more questions, answer those questions through our cohorts. So thank you again for everyone for joining us, and again to our sponsors that have enabled our network to launch and carry these training webinars forward. So thank you to all. Have a great day, and please view and share the link to the webinar with your colleagues as well.
And thank you for providing a forum for this important work.
Thank you.